Hi there, I'm Dr. Brian Lipworth, Head of the Scottish Centre for Respiratory Research. Today I'm going to talk to you about obstructive airways disease, and here are the key words which you can look at your leisure. These are the learning objectives, and to kick off I'm just going to give you an overview of where we are. So we're talking here about the conducting airways. This is where we get obstructive airways disease, and that's to differentiate it from the lungs, which is what we call restrictive airways disease. And you'll see the relevance of that when we come to talk about pulmonary function tests, which broadly speaking are divided into an obstructive and a restrictive pattern, but more of that to come later. The obstructive airway syndrome can be divided into three distinct pathological entities, namely asthma, chronic bronchitis, and emphysema. And there's another phenotype called ACO, or asthma COPD overlap syndrome, which we will go into later on. But basically, these are COPD patients who've got some reversibility to bronchodilator with a degree of eosinophilia who are responsive to steroids. In terms of the anatomy, I'm not going to spend too long dwelling on this, but as you know, the airway divides 23 times from the bifurcation of the trachea at the carina. We can divide this into the large airways up to generation 8 and the small airways thereafter. Another way of looking at this is the conducting zone, which is involved in gas transport up to generation 17, and the alveolar or acinar zone from 17 thereafter, which is involved in gas exchange. This figure just shows you the bronchi and lobules of the lung and illustrates quite nicely how the bronchial tree is invaginated into the lung. If we look at this in more detail, particularly the caption on the lower right, this shows the common basement membrane which abuts onto the alveolar epithelium and the endothelium of the pulmonary capillary. And basically, in terms of gas exchange in the alveolar air spaces, we're talking about getting oxygen from the inspired air across the alveoli into the red blood cells, and in contrast, getting rid of carbon dioxide in the opposite direction. If we think about the cause of airflow obstruction, this can equally apply to asthma or COPD. If we start in the lumen of the airway, which is shown here, the airflow obstruction can be caused by invagination from mucosal swelling, shown as the stippled area in the mucosa, and that will narrow the airway. And then around that, this pink area, this is meant to be a schematic cross-section of the spiral smooth muscle around the airway, which if that goes into constriction will also narrow the lumen. And finally, and this bit only appertains to COPD, is that there are alveolar wall attachments to the airway, to the bronchi and the bronchioles, and these keep the airway open. So if you lose the alveolar walls in a process known as emphysema, then the whole airway collapses like a concertina. If we start off with asthma and we look at asthma terminology, this can be broadly divided into type 2 high and type 2 low. And here we're talking about Th2 inflammation. That's one way of describing it, which is the modern way. There are other alternative classifications which we don't tend to use so much nowadays, which is early or onset, late onset. In other words, does it occur in kids or in adults? Is it allergic or non-allergic? Atopy and allergy are interchangeable. Or is it extrinsic or intrinsic? Extrinsic means there's an identifiable outside trigger factor, and intrinsic means there isn't. But in reality, you can have a mixture of any of these. So you could have a patient, for example, with late onset, non-atopic, intrinsic type 2 low asthma, or conversely, you could have a child with extrinsic atopic early onset type 2 high asthma. But don't get too fixed up with that. This is an important slide, and this is a slide that I invented called the asthma triad, and this shows you the 3 key tenets of asthma. Firstly, there's the type 2 airway inflammation, of which the eosinophil is the usual key effector cell. As a consequence of that, that generates downstream twitchy airways, what we call airway hyperresponsiveness, and also reversible airway obstruction as well. This slide shows the dynamic evolution of asthma, starting off with episodic brief symptoms. Then if the disease becomes persistent and you get persistent type 2 inflammation, this results in the exacerbations and airway hyperresponsiveness, or AHR. And finally, if it's left unchecked, the way the body responds is to lay down collagen tissue, fibrotic tissue in the airway, which is what's known as airway remodeling. And then you've got fixed airway obstruction. And these are just some of the hallmarks, the pathological hallmarks of remodeling in asthma, and I'm sure you'll get a separate lecture. Basically, thickening of the basement membrane, laying down of collagen in the mucosa and submucosa, and smooth muscle hypertrophy as well. And that's late stage severe persistent asthma. This is a brief overview of type 2 or Th2 inflammation, shown as an animated schematic. And I think you've probably been taught this already, so I'm going to just skip through this quickly. There you have the allergen. This is the airway epithelium. That then links on to something called TSLP, or thymic stromal lymphoprotein, which is involved in binding to the antigen presenting cell, or the dendritic cell. You don't have to know this, it's just for information purposes. It's quite a cool little animation. That then goes to the lymph node, and that then differentiates T cells into the Th2 endotype. That then interacts with B cells, producing some cytokines, namely interleukin 4 and 13. The other Th2 cytokine is interleukin 5. That's important because it's chemotactic for eosinophils. Eosinophils can't resist interleukin 5 like I can't resist fudge donuts. It's a very similar analogy. We then have immunoglobulin E, the archetypal allergic antibody, which then binds onto mast cells. And when the antigen and the IgE interact, that releases preformed mediators like histamine. Same thing happens in basophils as well, as you can see. And basophils also release another chemical mediator called leukotriene D4, which we'll talk about later on. Leukotriene D4 is important because not only does it attract eosinophils, but it also makes goblet cells produce mucus. So that's the basic pathway. The key cytokines you need to remember are interleukin 4, 5, and 13. And that's important because we can now block these with biologics. So just to recap, type 2 inflammation in asthma is the presence of the following endotypes, cytokines which are raised, 4, 5, and 13, raised total or specific IgE, usually both, the presence of eosinophilia in blood or in sputum, and the presence of raised fractional exhaled nitric oxide, which is a point-of-care test for measuring type 2 inflammation, which we'll talk about later on in the pulmonary function lecture. Now, this is what I call a money slide, because you're probably going to be examined on this. It's a slide which I devised and published in The Lancet a few years ago. It's what I call the inflammatory cascade. And this is important because if you understand this, then you understand the basic principles of asthma treatment. So think of the seed in the soil. The soil is, if you like, the genetic loading or predisposition, and the seed could be something like a virus, an allergen, or a chemical. That then triggers off the type 2 inflammatory cascade, with particularly eosinophils. 90% of asthmatics are eosinophilic, about 10% are non-eosinophilic. You then get release of these mediators, particularly histamine and leukotriene D4, and release of the signature Th2 cytokines 4, 5, and 13. What that does is it then sensitizes the smooth muscle to become twitchy, what's known as airway hyperresponsiveness or airway hyperactivity. So, on the right side, how do we treat asthma? Well, you can avoid the trigger factors, but in reality, you can't live in a plastic bubble. But if you've got, for example, a pet, like a cat or a dog, which is an allergenic trigger, then it's important that a particular person thinks about removing that from the environment, although it can take a long time for the allergy to clear, particularly cats. Cat allergen, which is actually on the saliva, on the fur, can take months to clear out. The mainstay of treating eosinophilic inflammation are the corticosteroids, abbreviated to steroids for short, and these melt away eosinophils, the most effective way of melting mucosal eosinophils. So that's first-line treatment. We can then add on second-line treatment with a mediator blocker, so something which blocks leukotrienes or histamines. And then finally, if the patient's still not controlled, we can think about monoclonal antibodies to block the signature cytokines, interleukin-5 or interleukin-4 alpha. 4 alpha is involved in signaling of interleukin-4 and 13, and we can also directly block IgE and anti-IgE. And finally, right at the bottom of the cascade are the bronchodilators. And these are either beta-2 receptor agonists, so these are like their own endogenous adrenaline, or muscarinic antagonists, which block your own acetylcholine signaling. This works on the muscarinic type 3 receptors. So thinking about this, if we treat the bottom of the cascade by giving patients regular bronchodilators, for example, using a regular beta agonist, that's a bit like giving a patient with appendicitis regular injections of morphine. You'll have a apparently happy, smiley, spaced out patient with no pain. That is, of course, until the inflamed appendix ruptures. So you're sort of sitting on an inflammatory volcano. Very similar here. You would never treat a patient with asthma with just beta agonists alone. So block the top of the cascade with an inhaled corticosteroid to prevent the bottom of the cascade from occurring. In other words, the amount of beta agonists that the patient uses, the amount of short-acting beta agonist reliever, is actually a very sensitive marker of whether or not you've switched off the cascade. So dampen down the cascade, minimize short-acting beta agonist use is the lesson here. If we think of asthma as an iceberg, using this analogy, the bit above the waterline is very easy to ascertain because all you need to do is to take a history to find out about symptoms and exacerbation. Then things get a little bit murky, but below the waterline, we can easily measure lung function with spirometry or peak flow. And then things get really dark as we start to get towards the seabed. We can measure bronchial hyperresponsiveness using challenge testing, but that's not something done routine in clinical practice, only in equivocal cases. And then really, at the bottom of the seabed is the holy grail, which is airway inflammation. And the only way you can really assess that is to do an invasive bronchial biopsy through a bronchoscope, which we don't do in routine practice. There is a point of care, non-invasive way of measuring that now using exhaled breath nitric oxide, which we will talk about, and that's now being rolled out into routine practice. This is just a picture showing through a bronchoscope a normal airway and an asthmatic airway. This is someone with acute asthma. And you can see there's a big difference between them. You don't have to be an expert. One's nice and shiny with a nice clear lumen, and the other one's boggy, narrowed, and horribly red. If you take a biopsy, then on the left is the normal airway, which looks nice and structured. the pseudostratified columnar epithelium standing to attention, a very fine, thin basement membrane which you can hardly see, and a very sparse inflammatory cells in the underlying lamina propria of the mucosa. Take an asthmatic patient and you can see it's completely different. It's just a total entropic mess. There's desquamation of the epithelium. The basement membrane is now much thicker and easier to delineate, and you've got inflammation of chronic inflammatory cells, including the eosinophils, in the mucosa and the epithelium. These are just biopsies taken from a normal subject at the bottom. At the top is a severe asthma patient who is alive, and you can see the epithelial shedding and the desquamation and the intense infiltrate of the eosinophils and lymphocytes. And unfortunately, this patient didn't survive, and at autopsy was found to have mucus plugging and a dense infiltrate of inflammatory cells. This next slide shows a biopsy of an asthmatic. Again, you can see a disorganized mess with the epithelium disrupted, basement membrane, the eosinophils, lymphocytes, macrophages. And then after a month's treatment with inhaled steroid, you can see it's completely changed. It's now got normal mucosal architecture with a normal epithelium, basement membrane, and underneath it a much sparser inflammatory infiltrate. Now this is really important because the only drugs which have been shown to normalize bronchial mucosal architecture in asthma are the corticosteroids, and that's why the inhaled corticosteroids form the spine throughout the asthma guidelines. When you're taking a history, you should also ask about trigger factors. Remember, I was talking about the seed in the soil. And symptoms can worsen in the presence of allergens, which I've listed there. But if you don't ask about them, you won't find out. And there are other trigger factors which I've also listed. The clinical syndrome of asthma is episodic. That's the nature of the beast. You can be okay 1 minute, and the next minute you can be short of breath, coughing and wheezing on exposure to a trigger factor. There is a hallmark diurnal variability. So what happens, patients with asthma get worse throughout the night and reach a nadir early in the morning, what's known as an early morning dip. And patients will tell you that. They wake up at night coughing and sneezing, and they're worse when they wake up in the morning and they have to use their short-acting beta-agonist reliever. They have a non-productive cough, usually, and they have a wheeze, which is a musical sound. You have to ask about the triggers, as I've already said, and also ask about type 2 comorbidities, like allergic rhinoconjunctivitis, chronic sinusitis with nasal polyps, atopic dermatitis, eosinophilic esophagitis, and urticaria. Asthma is responsive to steroids or beta agonists. It's reversible. You should ask about a family history of asthma as well, and ask about whether there's any wheezing due to turbulent airflow throughout the narrow bronchial tube. So diagnosis of asthma is mostly established on the history. The examination is not going to tell you too much unless the patient's actually wheezing, so it's mostly down to the history. You can give the patient a peak flow meter and look at that diurnal sawtooth pattern of diurnal variability of the peak flow rate while at home. You can measure forced expiratory lung volumes with spirometry, which we'll talk about later. You can see if they reverse to salbutamol, or in contrast, you can see if they bronchoconstrict in response to triggers like exercise, doing an exercise challenge, or a challenge with chemical stimulants like histamine, methacholine, or mannitol, which we'll discuss later on in the lung function lecture. This is just a peak flow to show the typical sawtooth pattern of peak flow, getting worse throughout the night and reaching a nadir in the morning. That's a typical pattern of someone who's got unstable asthma. Let's move on now to talk about COPD in the second part of the lecture. It's a multi-component disease due to smoking, comprising inflammation, mucociliary dysfunction, and tissue damage, and that develops to airway obstruction and progressive disease progression while the patient continues to smoke. The characteristics are frequent exacerbations and progressive reduced lung function, and the symptoms are breathlessness, a productive cough, and worsening quality of life. This is just a cartoon to show you the difference between a normal and an airway with COPD. In a normal airway, you can see, as I said before, the alveolar walls hold the bronchi and the bronchioles open. In COPD, you've got endobronchial inflammation with mucus due to mucus hypersecretion, and you've got disrupted alveolar attachments. So the airway is narrow from within and also from without. The disease process in COPD is due to smoking, which revs up alveolar macrophages and produces release of neutrophils, which release damaging proteases, which produces the destruction of the alveolar walls and also mucus hypersecretion. There are two distinct pathological disease components to COPD. One is chronic bronchitis, which is characterized by mucus hypersecretion. So patients will tell you they cough up a lot of mucus. It's usually due to chronic neutrophilic inflammation, but about 20% of patients with asthma COPD overlap syndrome can also have eosinophilic inflammation. And they're the ones that are responsive to inhaled corticosteroids. You get mucociliary dysfunction, an altered lung microbiome because your mucociliary escalator is not working. And you've got retained secretion. So it goes to more of a gram-negative pattern with bacteria like Haemophilus influenzae being present. You get smooth muscle spasm and hypertrophy, and it's only partially reversible to corticosteroids or beta agonists. In emphysema, it's characterized by destruction of the alveolar walls. Consequently, you get impaired gas exchange, loss of bronchial support, and this is an irreversible process. We don't have anything which can modify the process of emphysema. And patients will have, usually a bit of each component. So some patients might have more chronic bronchitis than emphysema, or vice versa. Most patients have got a bit of each, to be fair. There is a protease imbalance in emphysema. Again, it's the seed in the soil here. You have a genetic anti-protease protection. Some people have got more than others. Some people have got born with genetic no anti-protease, what's known as alpha-1 antitrypsin deficiency. Then in combination with smoking, you can see that would tip the balance towards breaking down alveolar walls, alveolar destruction, emphysema, and impaired gas exchange. The management and assessment of airflow obstruction is defined by the GOLD strategy, Global Strategy for Diagnosis, Management, and Prevention of COPD, abbreviated to GOLD, G-O-L-D. You should assess the symptoms, assess airflow obstruction with spirometry, ask about exacerbations, and ask about smoking-related comorbidity, ischemic heart disease, or heart failure. And basically, patients who've had 2 or more exacerbations within the past year, or who have lung function with 50%, less than 50% predicted FEV1 are indicators of high risk. And this is known as the GOLD assessment tool. So there's 2 ways you can assess COPD. The first is to assess airflow obstruction with spirometry, broken down into GOLD 2, 3, and 4, depending on percent predicted FEV1. And the second is to stratify according to exacerbation history, shown on the vertical axis, and symptoms shown on the horizontal axis. And these are either characterized by the COPD assessment test, CAT, or the mini Medical Research Council symptom score. So ask about symptoms, ask about history. The most common presentations are GOLD B, which have got lots of symptoms but few exacerbations, or GOLD D, which is lots of symptoms and lots of exacerbations. Don't see many patients really with C or A. So it's B or D that we're really talking about here. So you might say someone is a GOLD B patient, infrequent exacerbations but much symptoms, who's got, let's say, an FEV1 of 55% predicted. So they would be GOLD 2, GOLD B. The clinical syndrome, I don't expect you to know that, it's just for information. The clinical syndrome of COPD is that symptoms are chronic and persistent. They're not episodic like asthma. They're due to smoking. Most patients are non-allergic. There's a daily productive cough, whereas in asthma it's non-productive. The breathlessness is progressive. Frequent exacerbations due to viral insults results in further damage and decline in lung function. And if you've got chronic bronchitis component, that's characterized by mucus hypersecretion. And if you've got emphysema, then when you listen to the stethoscope, because there's alveolar destruction, you don't hear the normal breath sounds, they're absent or reduced. There's an inexorable chronic cascade in COPD, which is characterized by progressive fixed airflow obstruction, which results in impaired alveolar gas exchange with low levels of oxygen and retention of carbon dioxide. That's known as type 2 respiratory failure. Hypoxia then stimulates constriction of the pulmonary arteries and arterioles to produce pulmonary vasoconstriction, which results in pulmonary vascular hypertension, and there's an increased resistance in the pulmonary arterial bed. And that means the right heart, the right ventricle, has got to pump against an increased resistance in the presence of pulmonary hypertension. What happens initially, it puts on meat, it gets bigger, it hypertrophies, the fibers get bigger, and then eventually the ventricle dilates and you get right heart failure, known as cor pulmonale, the heart of the lung, also known as pulmonary heart disease. And once you've got cor pulmonale, your 5-year survival is less than 30%. But the key point here is that encouraging patients to stop smoking will arrest further decline in lung volume. So it really is important to get patients to stop smoking at any part of the disease process. Key learning point there. I am going to briefly talk about asthma COPD overlap syndrome because it's something which has attracted recent attention. So basically, these are COPD patients who've got blood eosinophilia more than 300 cells per microliter, which is the same as more than 0.3 times 10 to the 9 per litre. These patients, because they've got eosinophilia, they respond better to inhaled steroids in terms of reducing exacerbations. They're also more reversible to salbutamol. And actually, it can be quite difficult to distinguish a patient with ACO from, for example, an asthmatic smoker who's got airway remodeling. The two present very similarly. And to be honest with you, it doesn't really matter because the management is much the same. So what are they? Are they an asthmatic smoker with severe disease and airway remodeling, or have they got asthma COPD overlap syndrome? I'm not going to go too much into COPD management because I'm going to give you a separate lecture on therapeutics of airways disease. I'll focus on the left side, which is non-pharmacological. So obviously stopping smoking is key, with or without pharmacological props like nicotine replacement and nicotine inhaler patches. And these drugs here, bupropion or varenicline, which are antidepressants or drugs which work through the nicotinic pathway. We should immunize patients to prevent them getting influenza and pneumococcus, and I guess you probably add COVID to that list in 2021. Physical activity, pulmonary rehabilitation is important as well to get them feeling better, and if they are persistently hypoxic, then we give them oxygen for at least 15 hours a day through a concentrator to prevent pulmonary hypoxic vasoconstriction and cor pulmonale. We used to take blood off them, venesection, to take a couple of units off every now and again to thin out the blood so that it travels better through the pulmonary capillaries. We don't really do that these days because hypoxia stimulates production of red cells. We don't really do much lung volume reduction surgery. That would be to basically say resect emphysematous bully to allow the rest of the normal lung tissue to expand. I can't remember the last time I referred a patient for that. And some people are also into stenting, which is to basically to put in a stent to open the airways to keep them open. And to be honest with you, these surgical things are for a very small minority of patients. Pharmacological treatment I'm going to talk about in detail in the next lecture, so I'm not going to go into that today. So this is an important money slide. You will be asked about it in exams. It's a slide which I've devised, which contrasts asthma against COPD. So we're talking on this side asthma, and on the right side COPD. So non-smokers versus smokers, allergic versus non-allergic, early or late onset versus late onset, intermittent versus chronic symptoms, non-productive or productive cough, non-progressive or progressive decline in lung function, eosinophilic versus neutrophilic inflammation with the caveat of ACO in 20% of patients in COPD, diurnal variability or no diurnal variability, good corticosteroid response or poor response, good bronchodilator response or poor response. The next things are lung function things, which just learn them at the moment, and then we'll give you a separate lecture on those. Preserve forced vital capacity and preserve total lung carbon monoxide, single breath diffusion. And in COPD, those are reduced. Normal gas exchange in asthma, impaired gas exchange in COPD. So that's the end of the lecture. I hope you enjoyed that today, and we'll see you again for the next lecture on airway therapeutics. Cheerio for now, and have a great day.